Welcome, everyone. Happy St. Patrick's Day. I'm wearing the only green item of clothing in my wardrobe. And I just want to start by thanking you for your continued commitment to helping the state of California have a safe and equitable and transparent vaccine rollout, helping us improve our allocation and distribution efforts. And we have accomplished quite a bit since we started, first convened this group the Wednesday before Thanksgiving. And just want to express our gratitude for your continued commitment to this effort. And as we begin this meeting, I do want to take one moment to express my deep sadness and distress about the attacks on our Asian American community. My heart goes out to the victims in Georgia and to all of the victims of racist attacks across our nation, which seem to be too many these days. But for anyone who is experiencing distress or needs to reach out, I wanted to offer the CalHOPE Warm Line, which is 1-833-317-HOPE. That is 833-317-4673. And with that, I would love to pass it over to Dr. Pond for any welcoming remarks.
Thank you very much, Nadine, and good afternoon, everyone. And I, of course, want to echo my thoughts. And this is really a difficult time, I think, hearing about this situation. And again, just, I think it's hard for everyone. And I think really appreciate the unity that we can all have together and really standing against these kinds of hate crimes, no matter what race you are. I also have been reflecting, there's been a lot of anniversaries in the last couple months. And so reflecting on this committee and when we started, but actually, this week is the week that we issued our kind of first Bay Area and then California stay at home. And it was a really, really different time a year ago. So just reflecting and thinking how optimistic I am now. We've come a really long way. I will say I was doing an interview earlier and I told the media at the time, I did think it would be longer than 2 weeks, but I didn't think it would be as long as we are experiencing now. But here we are with a vaccine advisory committee and 3 amazing vaccines that have really high protection from hospitalization and death, and just really excited to be here. And we'll talk actually as I move forward about some of the great landmarks we've met with our vaccination. So thanks to all of you for all that you've done to contribute to that, both advising us as this part of this committee, and a lot of you are working on the front lines as well, helping make sure people get vaccinated and doing their part. And the last opening remark is just, I think I want to just say that we're really close and it's very exciting, a lot of optimism, but we can't let our guard down yet. We are so close, but if we could get intercepted, like this virus is a smart one, and it's very wily, and as we are hearing, is changing frequently. So I think we can, if we stay diligent, we can outpace this race with this virus, but I think we can't let our guard down. So just want to make sure people, are still masking, still distancing, especially those of you who aren't vaccinated. I think really we need to keep it up until we really can get more people vaccinated. And on that note, we'll be, we're talking a lot here at the state about what is beyond kind of the blueprint, and we hope to have more information on that in the very near future. So you can stay tuned on that and have more to look forward to. So I'll pause there. Thank you.
Bobby, do you want to walk us through meeting logistics?
Yeah, thank you. So just as a reminder to all of you, the members I think know the process, but for members of the public who might be listening, just as a reminder, the cameras for the members, we appreciate them being on, and everyone keeping your microphones on mute until you're ready to speak. Please use the hand raise icon, and that way we can easily recognize you and allow you to make comments and ask questions. We have our great 2 ASL interpreters, Katie Sales and Vicki Kennedy, with us again. We count on them for our meetings, and we also have closed captioning. I think as everyone knows, the public is listening in via an English and a Spanish telephone, listen only telephone line, and also watching the proceedings of the meeting through our live stream. And again, if any of you have members have difficulty with your Zoom, if you could put your question in the chat, we'll do our best to help you fix whatever the technical difficulties are. And Dr. Burke-Harris and Dr. Pond, if it's okay, I'll just go on to a summary of the public comments that we've received since the last meeting.
Please.
Our last meeting, which was on March 5th, the public comments closed on March 1st because, of course, as all the members know, we expected to meet on the 3rd, and then we needed to push that meeting off several days. So the public comments that you all received on Tuesday and the summary that I'll give today represents the comments we received since 5 o'clock March 5th until 5 o'clock on March 15th. We received 48 pages of public comment with links to additional materials. We heard from 218 individuals and organizations, all of whom wrote passionate and thoughtful comments that I'm going to summarize very quickly here, but you all have the full text of their comments, and I know you've had a chance to review them. We had one comment asking that public messaging and communications for the whole state needed improvement about where to get vaccines. We had another individual who wrote concern that inaccurate information, in their opinion, was being distributed by the Los Angeles County Public Health Department about the Johnson & Johnson vaccine. We had 4 individuals writing to find out where and when people 50 to 60 years old could get vaccinated. We had 8 statewide organizations write in to ask the Department of Public Health to provide more detail on where people with serious mental illness fit into the prioritization guidelines. We had 63 individuals and organizations write in asking us to prioritize people living in congregate settings, especially in prisons, county jails, and immigrant detention facilities. We had 3 individuals writing to ask CDCR, the California Department of Corrections and Rehabilitation, to reduce incarceration in state prisons to below 50% capacity and to prioritize vaccinations for staff and inmates. The following organizations and individuals wrote in asking us to prioritize higher on the list these sectors, workers, and occupations. All essential workers based on Governor Newsom's March 2020 list. Aviation workers, hardware store and home improvement store employees, automotive retailers, cosmetologists, hairstylists, personal service, nonprofit organizations working with refugees, port workers, food workers, plumbers. We also had a number of people ask that they be immediately put higher on the prioritization list. 5 individuals wrote who are parents or caregivers of children with special needs who are not connected to regional centers. 2 individuals wrote who are parents of children going back to school in person. 2 individuals wrote asking that college and university educators be higher up on the list. 1 asked that youth sports officials be higher on the list. 1 wrote that families of all essential workers be prioritized higher. We had a letter from one of our CVAC members organizations asking that people with Alzheimer's and dementia be higher on the priority list. 1 individual who is a Native American who has asthma asking to be prioritized higher. 43 individuals with type 1 diabetes. 6 individuals with cystic fibrosis. 1 individual with asthma and an autoimmune disease combined, 1 person with COPD, 1 person with a bone marrow transplant, and 1 individual who is blind, all asking to be higher up on the prioritization list. Another individual wrote and asked that that California has neglected all people with high-risk medical conditions. Another individual wrote asking that we broadcast widely what the list of the underlying medical conditions, what those medical conditions are, and that we widely publicize what they are and where those individuals can get vaccinated. The Council of Churches in Menlo Park asked that more vaccine be made available, specifically in Census Tract 6117 and other low-income communities around the state severely impacted by COVID-19. One individual wrote in and said that his or her doctor told the individual to get the 1-dose Johnson & Johnson vaccine, but they can't find out where to get it. 3 people wrote in and said they weren't able to get their 2nd dose of the vaccine that they already received. And a group of pharmacists wrote in asking that pharmacists be paid appropriately for providing COVID vaccines to the public. And that's our summary today of the public comment that was received through March 15th.
Thank you very much, Bobby. And now I'd like to head into our abundant business for the meeting. At our last meeting, we started out really by highlighting the many ways in which March is a time of transition, and it certainly has been a very busy time. We fortunately we were very excited about the announcement last week that the president is anticipating that our vaccine supply will substantially increase by May 1st, and that there's an expectation that on May 1st, eligibility will open to everyone. And so that's very exciting and promising news. I think in advance of that, we certainly want to highlight what the current eligibility is and kind of the plan to get between now and May. And as a result, you all know that we work very hard to try to get all of your questions answered and be responsive to the questions that this body raises about the eligibility and the allocation process. So we sent out a list of responses to many of the questions that have been raised by this body with answers, so you all should have received that. But I want to specifically highlight a few to pull out. And there, at a previous meeting, you all heard me say that when it comes to the question of who will vaccinate detainees of federal facilities in California, federal immigration facilities, my answer at the time was, I don't know. Now we have an answer. As many of you saw, California Department of Public Health released guidance last week that ICE detainees will be vaccinated by the state of California. So thank you for continuing to ask that question. I'm really glad that we were able to get you an answer. And that is the answer on that response. In addition, we're very excited about many of the farm worker vaccination efforts that are happening. We sent out information to members of this committee earlier about a number of vaccination events that are happening today all around the state and through the weekend. And so I just wanted to bring that to attention because there were multiple questions about farm worker vaccination efforts, and we just wanted to highlight some of the excellent work that's happening on behalf of our counties and our employers here in California. So today we'll hear an update on vaccine supply from Dr. Pan, as well as an update on our 3 federal partnership programs from Dr. Pan and Nancy Bartman. We will also hear more from our TPA partners on achieving and monitoring equity. So we look forward to that conversation. And as well, we'll hear more about our community engagement and outreach efforts, how we are reaching out to our vulnerable and hard to reach communities. And with that, I will turn it over to Dr. Pond.
Great, thank you again. Yeah, let's move to the next slide. So I think it's helpful as well to have heard a lot of those public comments in addition to some of the questions we were answering directly from all of you. I think some of these things will be answered in some of these upcoming slides, and some things we'd already kind of noted, but just to reiterate as far as eligibility and phases, et cetera. So let's move to the next slide. So, I like to always start with all of you, and as the state epidemiologist, just always kind of looking at our numbers, and we have hit over 3.5 million cases as of today, but our new cases are actually much lower. It's about 1,260 today. It's been ranging around the 2,000s, and a nice other statistic I was just noting, another local county had highlighted was sort of the ratio of vaccinations to cases. And I'm very pleased to say, looking at our numbers, we are vaccinating about 100 times as many people as doses as new cases every day. So we're probably, our average is about 200,000 doses a day. And we're, currently at about 2,000 cases a day. We're seeing really good trends as far as the cases decreasing, the test positivity decreasing. And then I'll talk more in a minute about overall vaccine administration, but good trends that we want to see continue. Next slide. And then this is just another way of looking at the trend as far as the actual cases. So the orange line, again, is the 7-day average. And this is looking at the first bump there is our summer surge. At the time, we thought that was a large surge. And then you can see our really large surge here over the holidays in the November, December time range, but that we are really on the downslope from that. And you can see we are similar to the kind of nadir last fall that we had when we were at our lowest number of cases. So we're at a similar point. We're not quite at the very lowest, I think, but again, encouraging to see we're close to that nadir. I will also just again give caution that last time we started reopening around the beginning of September as well.
Contacto, going back and forth and back and forth.
Could you please mute if you're not speaking? So we do anticipate and we'll be watching very closely to see if these trends turn around. But now we have vaccine under our belt as well as another tool. Next slide. So this is a nice sort of data to show as well. You can see we had very early on, kind of what our numbers were per day. This is basically the numbers of doses administered per day. And as I mentioned, we're reaching on an average around 200,000 doses per day. There's also a little bit of a time lag still in when, these doses get sort of registered in our system. So I fully expect that a lot of these, yellow and blue peaks here will start to fill out as we get more of the data. But as of yesterday, 12.6 million doses administered, which is really, really exciting again. Next slide. And to see how are we doing on equity. So that again is one of the primary missions of this committee to help advise us on this. And we know that we have a lot of room to go, but this is what we're starting to show so that we can monitor together and you can monitor with us how we're doing on equity. So this is a comparison of our COVID-19 vaccinations, both the first doses and then second doses amongst our 4 different levels of community health. So again, as you all sort of know, we've been talking about a Healthy Places Index developed by the Public Health Alliance of Southern California. And it can measure based on a geographic area, looks at impacts of health like income, education, access to health, and then areas are given a score ranging from the least healthy community conditions to the most healthy community conditions. And then we're also looking at an equity metric for areas that don't have an HPS score. So there's a lot of epidemiology behind that. But you can see that in our least healthy community conditions, we've gotten almost 950,000 doses, or almost 12% for a first dose, and then a little over 9% for that second dose. So as far as how does that compare, we are at about 15.5% in the most advantage and 18.8% in the second doses. So definitely not an equity here, but it was actually almost double a few weeks ago as far as the ratio. So I do think we're making slow progress. And again, these are benchmarks we're following closely. Next slide. And then again, really exciting to share. This came out on March 5th from the CDC Advisory Committee on Immunization Practices, but the new Johnson & Johnson vaccine, we like to call it the one and done vaccine, and really great to have yet another tool in our toolbox. Like the other two, Johnson & Johnson is safe and highly effective against preventing death and severe COVID. It's just one dose, so that makes it just so much more convenient that people don't have to come back for a second dose. It's easier to transport and store. And so again, a really great tool for helping us end the pandemic. There's also good evidence of this vaccine that does decrease transmission. That's been a big question about a lot of these new vaccines, and had done pretty well compared to other vaccines against certain variants, like the South African variant. So really the best vaccine is the one you can get when you're eligible. And many of you may have seen that Dr. Burke-Harris and Dr. Aragon and Dr. Galley and I all actually showed our faith and trust in this vaccine by getting our doses last Thursday. Next slide, please. So this is our overall vaccine dashboard. So you saw the breakdown by equity quartiles, and we already talked about overall doses administered. The other nice thing here that we're starting to show you is how many people are fully vaccinated. So over 4 million people in this sort of fourth row here are fully vaccinated. So this is almost 13% of our population that's eligible. So that is super exciting. And then this also tells you, doses delivered, how many of them are CDC pharmacy doses, and then there's breakdowns by county. Oh, and actually, sorry, the dashboard is a little outdated because our number on the far right is as of yesterday. So 4.3 million with 2 doses, which is 13.4% of Californians over 16 years old. So huge progress there. And again, over 4 million that are partially vaccinated as well. Next slide. So this came up in some of those public comments as well. Who can get vaccinated? So just want to reiterate again, and this is on our website, covid19.ca.gov. So the eligible groups at this point are healthcare workers, long-term care and skilled nursing facility residents and staff, Californians 65 years of age and older, and then 3 major sectors. So food and agricultural workers, childcare and education workers, emergency responders. And then as of March 15th, healthcare providers can use their clinical judgment to vaccinate individuals as well who are deemed to be at the very highest risk to get very sick from COVID-19 due to these severe health conditions. I think we're on the next slide, and then disabilities or illness. And then we did just also note that as of March 15th, as of this week, actually, sorry, back a slide again, that high-risk congregate living spaces are also eligible for vaccination. So this includes all our incarceration and detention facilities, as Dr. Burke-Harris mentioned, also homeless shelters, other congregate residential settings where we've seen outbreaks are all eligible as of this week. And then public transit workers have been clarified as part of our emergency service workers, and a few other updates have been posted on our website around that. I did just hear that public comment loud and clear about the health conditions. Those are also on our website, the detailed list of which health conditions were a subset of the CDC at-risk conditions. So for the next slide, I'll introduce Nancy Bargman to talk about implementation and the disability community.
Great, thank you, Dr. Pon. So it really has been a very universal and partnership in the disability community of moving forward with distributing and getting access to vaccines, and really appreciate the work of the implementation work group and the recommendations. And so I want to provide you just some real quick updates, particularly in the area for regional centers. Regional centers did receive a directive from DDS that outlined kind of the priorities, but also provided a sample letter that families and self-advocates could take to a location if there is a need for verification. While it's not required, there may be instances that letter may be of support to them in accessing. So we wanted to make sure that that was available. The regional centers are making individual contacts with all of their consumers and families For those that are between 16 and 64, right now is the focus because they already had made contact with those that were 65 and over, and also those in congregate settings. Regional centers and independent living centers are working together in the geographic areas where they can make those contacts to be able to have connections when a clinic is set up. So there's a coordination that's going to be of value in making sure that we are able to open the door for other individuals beyond the regional centers as they're doing their local work. Blue Shield has assisted with the department with being able to connect the regional centers with their local county public health departments, so we could really start addressing kind of those high risk and equity focus areas, specifically within the zip codes. And we have 5 different regional centers that have been identified as a priority based on some of the geographic areas that are harder to reach communities, and working to have some very targeted approaches and coordination. Also really pleased to see that we've been in contact with LA County. They're doing a coordination with all 7 regional centers in LA County. And we provided LA County information regarding the independent living centers in that area to have assist in that coordination. Vaccination, as far as the data, we are collecting by regional center for those families and self-advocates that are willing to report if they've received the vaccine. We've had some really good success with families reporting. We are requiring the congregate settings to provide this information as well. But we have had some instances where families have chosen to not share that information. We're able to collect that. We are going to be posting the information on our website as to how many individuals have received the vaccine, but understanding that some of the data is limited, as I was just stating. We also have a little bit of a lag in our data entry, and we will make note of that on our website when we have that information posted. I do want to give just some examples of some of the targeted efforts, because as we know, there's multiple avenues to access the vaccine. You know, the health provider, an individual's health provider, going to through the county or city. There's federal sites. There's targeted clinics. There's mobile options. And so to do a coordination at the local level is really, really critical. And that information often changes. And so regional centers are updating and making that outreach to their community to provide that information as frequently as possible. Also then making sure that we're updating any information on our website that would be of assistance. Just some examples of some of the targeted clinics that have been set up specifically for individuals who are regional center consumers. I have several of those listed. San Andreas Regional Center, as of this week, had 600 doses that were able to be delivered. Central Valley Regional Center has about 700. Golden Gate's updated number is actually 1,100. And then, as I noted with LA County, I do want to just also share that you can see that local connections between people is really making a difference. LA County Sheriff, there was a news report last night about LA County Sheriff has a mobile team that's going out to communities to distribute vaccines, and they had some extra that they wanted to go ahead and support the community. And so they were connected with a regional center, and they connected there was a really great family member who was able to make this connection. And so they had gone out to some individuals' homes yesterday and were able to deliver the Johnson & Johnson vaccine, and were able to do so to individuals who would have struggled in being able to go to a public site. So really, really pleased to see the coordinated effort. And so we're continuing to pivot as the need comes forward. So Dr. Pan?
Great, thank you very much, Dr. Bargman. And I think another thing I'll just add, and I put in the chat for people, we have a fact sheet that we issued at the end of last week around, again, listing kind of the high-risk medical conditions or disabilities and information about verification, which just to read out loud too, verification documentation of the diagnosis or type of disability is not required, but instead anyone meeting the eligibility requirements will be asked to sign a self-attestation that they meet the criteria for high-risk medical conditions or disabilities. So again, I think there's been a lot of good and healthy discussion about balancing, not having barriers to people who can get the vaccine who are prioritized with verification. So this is sort of where we have landed. And again, there's a lot of great information in the fact sheet that I posted in the chat there. Next slide. And then, you know, the other great thing around our overall equity approach is we have really used equity as a benchmark to help us move our whole state forward, because we know, as we've been talking in this group as well, that the largest amount of disease is in sort of the least advantaged quartile, the HPAC quartile 1. So we need to be vaccinating in that place and really monitoring that. So we met our first benchmark of 2 million, which is really exciting. I've shown you where we are in that. Our next one will be 4 million. And what happened when we met the 2 million was we changed that threshold between the red tier and the purple tier to give a little bit more room between 7 to 10 cases per 100,000 per day. So as you also may have seen from some announcements yesterday about Tier Tuesday, we had a lot more counties come into the red tier. There's only about 11 counties left, I believe, that are still in the purple tier. So our state is really making huge progress there. What will happen when we meet the 4 million benchmark of 4 million doses in the HPAC quartile 1 is that the threshold between orange and yellow will change just a little bit as well. So that'll be other exciting news. And it just sort of means, again, that we're on our way to our slow but stringent reopening and returning ourselves to our better normal. Next slide. Oh, and then this is also on our dashboard just to show you, this is the number again as of today, almost 2.4 million. So working our way towards the 4 million doses. And you can again look at the just pure doses by quartile on this dashboard. Next slide. And then a lot of people have been wanting to hear more updates on the federal pharmacy programs. So there are a few different ones. The federal retail pharmacy program is just sort of where people can walk into different retail pharmacies. So there's cumulative doses administered at retail stores in California as of March 8th. So you can see these numbers here, over 300,000 at CVS, almost 200,000 at Rite Aid, over 120,000 at Walgreens, and over 200,000 at Albertsons. And at these pharmacies, they are vaccinating the current eligible groups. So that includes, again, 65 and over, healthcare workers, long-term care residents and staff, and then our 3 major sectors that are eligible. And then also a federal directive was that the pharmacy partners needed to prioritize pre-K through 12 educators and staff and childcare workers during the month of March. So during this whole month, educators are prioritized at these 4 pharmacy sites. And then as we mentioned again, on Monday, the group of individuals under 64 years of age with those comorbidities, those high-risk conditions are eligible as well. Next slide. So let's see, and as of March 7th, an additional 36,000 doses of Pfizer were allocated with this federal retail pharmacy program. And then CVS has just expanded an additional 119 store locations. So as there's more supply, the program will expand to more locations. And over 280,000 doses were allocated for the week of March 7th. And we are entering the week of March 14th right now. And these are the doses that are being allocated here this week. So Janssen doses as well as an increase in Pfizer doses are coming to us. And with the expansion of Janssen doses, there are 4 long-term care facility pharmacy partners that will be activated this week. And those are MHA, Innovatix, GeriMed, and Cardinal. And then PharMerica is under the Innovatix network. So that's also great news as far as expanding the partners that can be distributing vaccine in California. Next slide. And then as far as the long-term care facility partnerships, so as you all know, those were with CVS and Walgreens, and they had committed to doing 3 vaccine clinics on site. This program will be ending at the end of this month. The SNFs started at the end of December, and then the assisted living facilities started a couple weeks later on January 11th. So as of the 12th, according to our CDC data, there have been almost 850,000 total doses administered, and you can see the breakdown here of first and second doses, how many resident and how many staff, and then a nice graph here as well, the cumulative doses administered in this program. Next slide. And then the other pharmacy initiative from the federal government is the FQHC initiative. So HRSA and the CDC put together a partnership to directly allocate a limited supply of vaccine. This is a separate allocation outside of our normal state allocations, and it's deployed in coordination with us. Incrementally, it started at selected HRSA-funded health centers that specialize in caring for hard-to-reach populations and disproportionately affected populations. So again, with an eye to individuals experiencing homelessness, public housing residents, migrant and seasonal agricultural workers, and then patients with limited English proficiency. So this is phase 1, and it's increased access to vaccines for 250 health centers nationwide. So there's a 4-week rollout of this FQHC partnership, and we now have 40 FQHC organizations participating that serve close to 200 individual sites in California. Cumulatively, in this program, we received close to 185,000 doses over the last 4 weeks. And then there's some frequently asked questions about these sites and additional information at this HRSA website link. Next slide. So I think with that, I will stop, and those are our general updates from CDPH.
Erica, there are a few questions in the chat that I think that we can jump to very quickly before we get to the overall Q&A. One question for the Federal Pharmacy Partnership, should eligible people use the Federal Vaccine Finder site to make an appointment, or is that system connected to My Turn?
That is a good question that I actually don't know the answer to, but maybe one of our next speakers does.
Okay. And another question, does the Federal Retail Pharmacy Program follow CDPH guidelines or the Federal CDC ACIP guidelines for eligibility?
So we've asked them to follow CDPH guidelines as far as eligibility, and that's what we've asked them to do, but it is, they also are relying on self-attestation.
Great, thank you. And I just want to, if you could check me, Erica, because I believe that this was in the information that was sent out previously, but the numbers on the county vaccine rates, they do include the federal partnership numbers, correct? The federal vaccine numbers?
I believe so, but we should probably double check on that one as well. This has been evolving. The data has been evolving as well.
I've got like 50 pieces of paper here, but I believe that this is, it is here. So I think it's in the information that got sent out yesterday. Yes, and with that, I think those are the primary ones I think directed at you. The other, confirming that the case rate to move from orange to yellow once we're over 4 million, that goes to less than 2, correct? Based on the
from orange to yellow, yes, it goes to less than 2. That's right.
Great. Bobby, you want to take it away?
Yeah, that's great. Okay, first I'd like to just check with David Lown. David, did you, we're going to keep the slide down just for a few minutes. David, I just want to make sure you didn't have a question. You had your hand raised earlier and it's gone. And after David, whether he asks a question or not, we'll go to Kieran and then Aaron and then Andy. David?
Yep. Yeah, David Lown, California Association of Public Hospitals and Health Systems. I put it in the chat. Dr. Aragon's provider information notice explicitly stated that SMI and severe SUD or be considered under the disability list, but those are not included in the CDPH public fact sheet or other notices. And it also calls out the attestation, which is also not listed on anything else that's public. So is his notice published anywhere on the website? I couldn't find it on CDPH or DHCS.
Erica, you're on mute. We'd love to hear you.
Sorry. You think you always just get this right. So the fact sheet, I had already put the link in, and I can put the other link to it. But yeah, the provider bulletins are also on the CDPH site. And those are listed on they're listed on the fact sheet.
So SMI and SUD is not listed on the fact sheet.
Okay, but it's in the provider bulletin.
The attestation is not listed on the fact sheet either.
So we will look at all this. Thank you for the feedback. I could have sworn I just saw the attestation on the fact sheet, but I will also put the link to the provider bulletin that has the SMI and SUD in it. And then we will work on better aligning it. So thank you.
Thank you.
Great, thanks David for raising that. And the fact sheet was sent out to all the members on March 11th. And Erica, just so you know, it's sometimes very hard to find the provider bulletins on the CDPH website. So there's a lot of navigation that's needed. So let's go on to Karen, and then Aaron, don't forget to introduce yourselves.
Sure, thanks Bobby, and thanks to the co-chairs, Karen Savage from CPEN. First, really want to thank you for the work on getting the ICE detention facilities issues sorted out. It means a lot to the probably 2,000 folks there right now, and so I really appreciate the work on that. I know it wasn't easy. And then sort of a question on the equity data that was presented. One thing just to note, what wasn't presented was the race ethnicity data. And if you look at the most updated data, it isn't significantly improved from a month ago, despite the focus in those lowest HPI quartiles, which I think is surprising and also worth paying attention to. There's a slight improvement for the Latino population, but otherwise more or less the same inequity that we saw a month ago. Which I think is also worth paying attention to, given that the eligible population now is bigger and more diverse. So it's potentially even more of an inequity than we had a month ago. So just want to point that out, and hopefully in future meetings, you know, it'd be great to look at that data along with the HPI data, because I think it tells us in some ways two different things. The other thing we see in there is still the really poor data collection, a lot of missing data. And so would love to talk about how we can improve that maybe in the next section today. And then the question is, looking at the data you had, Dr. Pond, by HPI quartile, in the lowest quartile, there's a bigger difference between people who are partially vaccinated and people who are fully vaccinated, or really a very low number of people who are fully vaccinated. And I'm wondering if we think that's because we sort of got started late working in those neighborhoods, and so we're catching up with getting people fully vaccinated, or whether we're seeing any problems with a greater number of people not going in for the second vaccine, and sort of what we think the issue is there, and how we might proceed in addressing it.
Yeah, thanks for all of that. I think for your last question, my hypothesis, but we need to look into this, so agree, we need to take a closer look at it, but is that we got started late and that we are, you know, sort of just now really attending to those first doses. Because, you know, we did just start that higher level allocation. I was trying to remember which date it was, but so yeah, but we need to take a look and make sure that there's good follow-up. I have heard excellent at least one of the FEMA sites. There's been excellent follow-up on the second doses there, and that has been again a mix of reaching the populations we need to, but it is a non-traditional site as far as not, you know, a healthcare clinic or things like that. And I've heard there's over 90%, I think it's actually better than that, who have returned for their second dose. But we will be taking a look at that. And yeah, definitely appreciate all that. We can talk more about that next time, and our additional equity strategies that we're working on as well.
And I'll just add to that, Karen, that we are looking at the data by HPI and also looking at the data by race. And to your point, we are looking at where our strategies are adequate and where they're not adequate to the task of reducing inequities, and how we can double down. So it wasn't presented today, but we're looking at that. And importantly, and you may hear more about this from our TPA partners, but the TPA is building that into their dashboard, looking at our equity strategies, not just looking at HPI, but also looking at race and ethnicity data.
Thank you.
Great, thanks, Karen. Let's go to Aaron, and then after Aaron to Andy.
Thank you, Bobby, and thank you, Drs. Burke-Harris and Dr. Pond. I really want to have a lot of concerns and questions about the equity, but I'll hold off until the next section of the presentation, which is about monitoring the equity. Yes, ma'am.
Introduce yourself.
Glad to. Hi, everybody. I'm Aaron Carruthers, the Executive Director of the State Council on Developmental Disabilities. I want to just really say thank you. Today, this week was monumental, was phenomenal in the state's leadership about inclusion, about equity, and really thank you for listening and responding, especially around the issues of self-attestation. The guidance that came out on March 11th really addressed a lot of worries, a lot of concerns, and it made sure the state adopted an abundance model approach to vaccinations. I know even though we're in a scarcity time, we still needed to establish systems and create approaches that anticipates the abundance that's coming. So also really appreciate seeing the inclusion of other populations that are very much in need of the vaccine. And my question, so I want to say thank you, and thank you to Director Bargeman for her continued leadership as we're looking and monitoring how systems are signaling to people with high-risk health conditions or developmental disabilities. We know some of the healthcare plans will be monitoring and sending. We also think that it's necessary that the departments continue their plans and their leadership to send the letters so people know how to get the access and are receiving those supports. So thank you, Director Bargeman, and thank you, Drs. Pond and Burke-Harris. Question is, with the addition of the additional populations on March 11th, what's the estimated range of Californians who are now stated in the eligibility population?
So I'm going to tell you what I think I know, and then we will also follow up in any follow-up emails. But I know that with the high-risk medical conditions, we were estimating about 4.4 million. And then the congregate settings was less than, it was a few 100,000. I want to say it was less than 500,000, I think. So around another almost 5 million, I think, was the addition on March 15th.
And did that include transportation? There were some other groups in there too.
There are some new groups that got sort of clarified as part of emergency service workers and added, and those were also smaller numbers. So we can get back to you with the updated total.
Great. And the reason I ask is that it helps us in messaging back out to the community about availability. My presentations to the community have been about eligibility versus availability. You're eligible, it's not available, but here's the numbers and the realities of who's eligible and the numbers of vaccines are actually in the state. And so far it's been, a little bit less than 50%, and that helps people really understand the situation. So thank you.
Sure, thank you. We'll follow up for sure.
And thank you for your work and your leadership and communication.
Yeah.
Hey, Andy, let's hear from you. And don't forget to introduce yourself.
Yes, hi, Andy Imperato with Disability Rights California. Just want to echo Aaron's thanks, especially on the broad categories that are categorically eligible, people with disabilities between 16 and 64, and the self-attestation. We're very grateful for where you all landed on both of those issues, and thank you for engaging with us around that. I also just wanted to let everybody know that next Friday, the Biden-Harris COVID-19 Health Equity Task Force is meeting publicly, and we're going to be voting on recommendations related to vaccines and equity. So I just wanted, for the folks here from the California Department of Public Health and then all the other stakeholders, if you all have ideas of things the feds can do that would advance equity and help California achieve some of its goals, I love your ideas. I put my email address in the chat for people listening in the public. I'm andy.imperato@disabilityrightsca.org. But welcome ideas. I'm one member of that task force. I don't speak for the task force, but I know we're interested in getting as good ideas as we can from as many different sources as possible. So I just wanted to put that out there.
Thanks, Andy. And I'll send the members your email along with Myra Alvarez from the Children's Partnership, who's also represented by Gabrielle on this task force, who's on the equity group with you. So thank you. Carol, let's go to you. And then Linnea, did you take your hand down? Did you want to say something after Carol? Well, Carol, you go ahead and then we'll find out if Linnea is going to speak or if.
Hi,
Go
I'm
ahead.
Carol Green with California State PTA. I just had a couple of points. Self-attestation's new for me. I always love when I learn something new. I want to just also tell you, I've been seeing ads the past few days. Come to the doctor's office and get your doctor's note. So I'm not sure that message that you don't need a doctor's note has gotten out there. And I'm also concerned there might be some people that are trying to profit off of this system. I haven't, of course, looked into it, but I just wanted to tell you that. And my second concern with equity is still about computer and internet access. People are wondering where there are, and I know there are small outreach, but some kind of a statewide plan for those that don't have computer or internet access would be a great benefit. Thank you.
Yeah, I think what's happening with that is very much at the local level. And so, but, you know, from the state and the TPA kind of working with making sure we are working with providers and or that those providers are working with community-based organizations to, but it's definitely a huge issue. And I think have heard a lot of great success stories actually about health departments or FQHCs working with partners to enroll and help, you know, sort of use the phone and or in person and enter for people to get their clinic appointments. But it's absolutely, you know, an issue, you're right, that we are trying to address sort of at that local level. And I think then if we, as we do that, if we can do it successfully, we're collecting the data as well, which is, again, early on has been a huge challenge. And, you know, as Karen brought up, we have data completion issues. And so trying to, again, always to check all the boxes that we can to get where we want to be, which is vaccinating our most disproportionately impacted people.
Thank you for raising that, Carol, and thank you also. There was a comment in the chat around pharmacies charging for vaccine, and we know that vaccine should be free for everyone, including at pharmacies. And so it's an opportunity for all of us, for all of you, to reinforce to your networks that there should be no charge for getting access to a vaccine, for receiving the vaccine. There should be no charge, and there's certainly undoubtedly unscrupulous, either genuine mistakes or unscrupulous individuals who are seeking to charge.
Thank you. So Linnea, did you want to make a comment? You just shake. Oh, there you go. Go ahead.
Yeah, Linnea Koopmans. I'm the interim CEO for the Local Health Plans of California, and I did take my hand down because my comments about equity, but I'll say it now and I'll be brief. But I just wanted to urge the state to continue considering Medi-Cal penetration as another proxy for equity. So I think, you know, when I've heard from our local plans that a number of them have looked at rates of vaccination for eligible members, and that it lags far behind the general population who's eligible in their counties. So while the HPI is, you know, of course related, I don't think they're equivalent. And so I really do want to urge us to continue looking at Medi-Cal penetration and maybe more formally incorporating that into how we're measuring equity.
Thank you, Linnea. And we're going to talk more about equity with the TPA in just a minute. Sylvia, one more question in this section, and then we'll go to our next presentation.
Thank you, Bobby. I just wanted to raise, pardon me?
Introduce yourself.
Oh, yes, of course. Sorry. I'm Sylvia Yee with Disability Rights Education and Defense Fund. I think the comment actually relates to what Dr. Pond actually said earlier, talking about like assisting partners, pharmacies, et cetera. Some of the issues I've heard around self-attestation, which is a great thing. I'm really happy about that, but that pharmacies have check down lists, let's say, when you're trying to make appointments, that really heavily emphasize the medical conditions. And if you don't have one of those specific conditions and say none of the above, then you're sort of punted out of the high risk category. You can't anymore indicate that that's an issue, which is problematic, obviously, because there are other ways of being a high risk person. So I think that especially for those who are receiving home and community-based services, for Medi-Cal individuals, that if that's the case, then they're stuck. And to the degree that the TPA, that the state can provide assistance, maybe some kind of clear screening tool that pharmacies or other vaccine providers can use, that would be extremely helpful to stop some of these implementation problems on the ground. Thank you.
Thank you for the suggestion.
Thank you, Sylvia. And Nadine, I'll turn it back to you for our next presenters, and we'll bring up slides for that section.
Thank you. So now we'll have an opportunity to dive deeper into a conversation about equity and hear from our TPA partners, Peter Long from Blue Shield of California and Kimberly Good.
Good afternoon, everyone, and thank you for the opportunity.
Kimberly, could you speak up a little bit, please?
Yeah, I think I'm going to get as loud as I can. I think my mic just died. Can you hear me now?
Yeah, that's much better.
Okay, I'm not sure what's happening. Thanks for the opportunity to be here. I echo the appreciation to Dr. Burke-Harris and Dr. Pan and really everyone in the community that has worked together to get us to some milestones. We're still in the thick of this, but we have to all feel good about the fact that cases are going in the right direction, deaths are going in the right direction. We've got more vaccine options. And I love the phrase I heard about getting closer to a better normal. So certainly our work at Blue Shield as the third-party administrator for this vaccine process, working with the state, that is absolutely our goal, to help us build the network that will prepare us for the abundance that we hope is to come. And certainly to work with all of the partners in each of the local health jurisdictions and across the state and in the community to do all we can to meet our equity goals. And ensuring that the distribution of the vaccine absolutely lines up with the disease burden, which is such an important way to ensure that we do get to that better normal. If we go to the next slide, I've showed this slide the last time we were before you, and the reason that we focus on the next one, this particular slide, is because it highlights the state's 5-point plan for vaccine equity. And it is certainly what we are grounded in as we approach our work. The third-party administrator does not have direct accountability for everything on this page, but we certainly have a delineated responsibility to provide recommendations from an allocation perspective that line up with the requirements set by the state from an eligibility point of view, as well as the allocation distribution. So it's our job to look at the data and to make those recommendations. We play a really big role in the network to ensure that we not only have an adequate network, and adequate means not only that we have coverage across the state, that we meet certain criteria like proximity to a vaccination site, but it also means those things that are important from an equity perspective related to the extended hours, the availability outside of traditional working hours to accommodate the needs of the community. It means access supports, things like transportation or language services. So it's our job not to accomplish all those things on our own through the network, but to ensure that we're partnering with the local health jurisdictions, other community-based organizations, to ensure that the community, the supports that are available to encourage access line up with the actual network. We also play a role on the data and analytics side. There's certainly been a push for us to get providers on the MyTurn system. The reason for that is that we want to make sure that we have a complete data set and that we have robust data, transparent reporting, so that we can know where we are, know how we're doing against our objectives, and can make necessary adjustments along the way. So those are the three areas where we have the most direct involvement. And then we are partnering with the local health jurisdictions and others across the state to ensure that the work we need to do on the community partnership side or the public education side are complemented. If we go to the next slide, I'm going to just speak for a couple minutes on two of the areas. And I think it's really important to understand that in addition to the work we're doing as a TPA, we're working very closely with the local health jurisdictions who every single one has developed an equity plan. And when we see that plan, it then helps us identify where we have things that are covered, where there might be needs and gaps, and then we work together to figure out how to action that. And we're just in the early phases of that because those plans were just developed in the last week. But that certainly is going to be a helpful way for us to know that on the ground, we're actually meeting our goals. So on the allocation side, we all know that the state has made a determination around how we should equitably distribute the vaccine. That's straightforward, that our job is to make sure that that happens. We also then will be doing the data collection and monitoring to make sure that we can account for if the vaccines were distributed to the first quartile in the appropriate manner. What was the uptick rate? How much are we vaccinating in those quartiles so that we're able to know how we're doing and be transparent about that. We also need to make sure that we're utilizing tools to ensure access to the vaccine for closed clinics or other groups that may help us meet our equity goals. We know that there was some preliminary gaps. This was not necessarily as a result of the TPA, but it was a learning for us to use going forward, that we needed to tighten up the process of how that worked. And I think the teams are working together to do that. But those closed clinics will enable us to provide a coded clinic access so that we can go to targeted areas as a way of meeting our needs. We also know that, we want to be ready from an allocation point of view as the abundance phase starts for the state. So we want to make sure that even as we open up eligibility, we are able to accommodate and direct people and get them signed up in the right proportion. As the state does become more open, we picked up on, I think, someone else's messaging that it's great to be eligible, but until we get to the abundance phase, it doesn't mean that eligibility will directly result into access, because we still do have a supply issue. So we're partnering very closely with all parties to make sure that the communications piece is clear in that regard. From a network perspective, as I already mentioned, we certainly have goals around proximity to providers, but we had a really rich discussion even this morning on the leadership team call that, proximity is not the only measure of adequacy, because clearly the needs of some who can get across town, as Dr. Burke-Harris represented on the call today, can be easier than for others. So there's more work that we need to do to make sure that even if there's a clinic that's easily accessible and meets the standard, that there are the access supports in place for those circumstances for folks that may not have a car in the home or other criteria. I will say that the proximity standards we are using are narrower than what was prescribed by others. So we do have more sites even than what had been established as a guideline, but we don't think that's sufficient in and of itself. We know that there needs to be some additional access support, and we're working to do that in partnership with local health jurisdictions. One of the ways that we are increasing access to meet our equity goals is through the multi-county entities, those providers that serve across the state. They have agreed to vaccinate all community members, not just their own members. And we think that's a huge way of making the vaccine accessible to all. We've made great progress in getting FQs and other community clinics into the network. We know that these are the trusted providers that many of the communities we are trying to reach rely on. And we're very happy that they're part of the network, and many have already begun the onboarding process. We did hear someone talk about technology as a possible barrier. So again, we consider that one of the supports that we have to have in place to help people who may not have access to technology. We have a 1-800 number or whatever the number is. I don't know if it's 800 or 888, whatever the number is. There's a number that people can call if they need help. And there are other tools that will be put in place through community organizations to facilitate reaching folks that may have a technology barrier. We also are trying other provider approaches like local independent pharmacies where there might be limited access to providers, mobile solutions that can address particular needs. And obviously we want to make sure that we've got enhanced coverage in the first quartile, HPI quartile, that could include things like extended hours and on-site solutions. So this gives you a sense as to how we're approaching our recommendation and input into the allocation part. I always have to remind people that the TPA makes allocation recommendations in partnership with our local health jurisdictions, but the final decision always is the state's decision. We don't make allocation decisions. With that, I want to turn it over to my colleague, Peter Long, who will talk about that third area where the TPA plays a role, and that's in the data analytics side. So he can walk you through a little bit of how we will approach measuring our progress and things that we will do to hold ourselves accountable. So I think something just happened there, but I'm going to turn it over to Peter, and if he can read that slide, he can.
Thanks very much, Kimberly. Let's see, second time's a charm. I think I put the dogs elsewhere today, so I'm trying to be learning in this process along with all of us. The headline for the data dashboards, and I think you all have been talking about what information do we need to know. So we've gotten information, and the state has had information through, for several months now on what the impact is, right? So what is the equity impact in the first quartile around the vaccination distribution? But we haven't always known why and what's underneath it. We have some, theories around that. And some ideas, but we haven't had the information to tell us what's happening. We also haven't had, and I think you've also raised this around race and ethnicity, potentially around insurance and Medi-Cal, other cuts of the data that allow us to understand what's happening underneath those bottom line results. So what you're seeing here are dashboards, operational dashboards that we've developed as a third-party administrator that help us begin to answer those questions. They don't provide all the answers because I think you all, with your kind of human insights and your on-the-ground experience, will be able to interpret the data and understand how do we take action to achieve our goal of equitable vaccine distribution. But this gives you a sample of a couple of I have two slides here of a couple of different dimensions. On the left here, it is around vaccine hesitancy or vaccine confidence, willingness to take the vaccine. So understanding, in that case, you can imagine how that's actionable of informing the public outreach campaigns, right? And how do we have more folks like Dr. Pon and Dr. Burke-Harris and Dr. Aragon being vaccinated publicly and working on those issues. You can see on the right, we're looking at issues of race and ethnicity. I think, Kieran, you raised earlier that we're not necessarily, we're not making up ground on that, but we need to know and understand by age group, is it a particular, what's happening by age group? Is it seniors of color? Is it younger adults? Where are we falling behind and where are we tracking? So the purpose of this is not the end all be all, and I'm actually gonna ask for your input on this one, but this gives you, gives us a couple of other cuts of the data and ways to look at it, so that then we can take action to actually drive closer to our equity goals. So next slide, and I'll give you a couple of more examples, and then actually at the end, I'm gonna ask for your input of other cuts of the data that you think would be important, particularly to drive action and inform action to achieve equity. So these are a couple around the allocation, so we can actually track, was it an allocation issue, and then did it flow all the way through to actual vaccinations, and how did that play out? So maybe we have an issue that we're distributing it in a certain way and we're not actually getting for appointments, or it's, how do we market it, or how do we get folks into the vaccination sites to map and match up where we've done allocations. The second is to look at the mix, as Kimberly showed, we now have an incredible array, a mixture of delivery mechanisms for the vaccine, mobile, in-home, in-clinic. We have federally qualified health centers. We have a diverse set of tools. And so this on the right here, again, it's illustrative and we're working on the data, but can show us that federally qualified health centers, we have a good clue that they would be very important, or good evidence historically, they'd be very important in reaching the first quartile. But how does that mix play itself out in different quartiles, in different geographies, with the goal then of informing future actions? And then this gives us, and Kimberly had mentioned, while we did set a geographic target of vaccine accessibility, how does that play out against quartiles? So these are some of the dashboards. The intention here is that they're operational. They'd be fed back to state leaders through the third-party administrator, and then across government to local health jurisdictions to drive future action so that we actually target the vaccines even more effectively. I'll do the next slide, and then I'm going to ask for your input because I'm sure you have lots of ideas of other types of data we should be collecting, other things we should be learning so that we can be more effective. What this slide is, and I think you've heard the words in the presentation, but what this slide is just shows, I think we're on the cusp of having a system that actually has a feedback loop where all of the components fit together, which is incredibly important because it allows us then to learn. It allows us to actually make the adjustments in different pieces of the delivery system and the data and the support structures so that we can actually then, as I said, work and have this process continue to improve over time as it has been doing. And what we've done here is lay out in different ways, it's a version of Kimberly's slide, what role the state plays in setting eligibility, the equity framework, allocation, and methodology. As Kimberly said, the local health jurisdictions, we have 61 incredibly detailed plans of how each local health jurisdiction believes we will achieve vaccine equity. And that's the guide, right? Those are the guide at the local level. And we'll share with you, I think maybe at one meeting or when they're ready, it has who are the providers, how do we achieve high priority populations and meet those, what are the resources that they need in order to be successful. So it's an incredibly comprehensive look, county by county, jurisdiction by jurisdiction, of what it will take to achieve equity. There's also the local provider insight and the local networks, and then those community partnerships. And then Kimberly outlined the three primary roles that the third-party administrator is playing: allocation recommendations, the network adequacy, and making sure that the network meets the needs, and then what I just went through, data and reporting. And then what we'll hear about next is I think we have incredible resources through the state's planning and wisdom around access supports. So with community-based organizations, the outreach campaign, and what the goal, I think, going forward as we move into an era of abundance is how do we make this work like a system? And so any thoughts as well and input you have there, what could we do better? What is the right feedback loop? What's the cadence for that? I think would be really appreciated, because I think this will determine whether we take our potential and all the inputs we have to achieve equity and whether it actually shows up over the next month, 2 months, and beyond. So let me stop there, and I ask for input on a couple, and obviously always take questions and others, but the input about what types of information you think will be critical to informing our action on equity, and then your feedback on this, how do we turn this into a system?
So Peter, if I could suggest that everyone put into the chat their ideas about the answers to your questions, because we won't be able to hear from everyone. And we already have a few questions lined up. So if you want to just repeat your questions so people can start giving you input through the chat. And while you're doing, after you do that, then we'll hear from Deborah and then Diana.
So 2 questions. One is, the inputs on data. So we heard about Medi-Cal, we heard about race and ethnicity by age. If there are other things that will drive our action towards greater equity. And then the second is, what's the right cadence in a feedback loop? How do we make all of the elements that we now have ready to go and actually are working? How do we develop that feedback loop so that we can continue to learn and improve as quickly as possible to achieve our goals?
Great, thank you. So in the chat already, from before you started speaking, a number of members raised up the issue of sexual identity and gender orientation. Sorry, sexual orientation and gender identity. just so you don't forget those on your list. So Deborah, why don't you introduce yourself and let's get started with your questions for Kimberly and Peter.
Okay, thank you for that presentation. I'm Deborah Shade from the California School Board Association. I guess a general question that I'm still struggling with is the relationship between your work that you're doing as a third-party administrator and the county. I know I'm hearing and reading in the paper and getting news reports and information from our county. They don't want to work with a third-party administrator. I know there was LA County, San Diego County, Santa Clara. I think there are multiple. So I really think it would be good for the group as a whole to get a pretty good understanding. Is that an opt-out situation? How it's all going to come to how will the county be responsible for this work if they don't work with you, and how that would affect the equity work as you see it rolling out in California? Thank you.
Peter, you're on mute.
I know, I just figured that out. Let me provide a third-party administrator response. Normally, Marta Green would be with me as my partner on the state side, but she's unable to join us. We are committed to continue working with every local health jurisdiction. We have met with every local health jurisdiction, all 61, and together have built the transition plans that include the equity plans that we're talking about. The state is in discussions with local health jurisdictions, with the counties to develop, they have an agreement, and we are hopeful that those counties will be agreeing to that, and we will continue to do our work in partnership and in support of the local health jurisdictions. We can say that the majority of counties have onboarded at least one clinic to the My Turn system, so we feel good about that. And we, again, are really optimistic that we'll continue working together to achieve the collective results.
And Deborah, I'll add from the state perspective that it is certainly our hope that the counties will work with the third-party administrator to ensure that our Californians get vaccinated. And I think that anytime you're launching an initiative as large as this and such a substantial vaccine campaign, I think there are always going to be efforts to be, negotiating and be back and forth. But the state is in partnership with the TPA. So in terms of, for example, I know that one of the issues that has been brought up is an issue of allocation. For example, the TPA is enacting the state's allocation guidelines, and so it's really we're setting the guidelines. So I think that there's a matter of, I think, negotiation. We understand from the TPA that they have been working with counties to make sure that needs are met and make sure that they can work through those details, but that's certainly our hope.
Okay, let's go on and hear from Diana.
Thank you, Bobby. I'm Diana Tellefson Torres, Executive Director of the UFW Foundation. I did bring up during the last call the concern regarding occupation being captured as food and agriculture and not separating out farm workers from other food workers. This is going to be very important. I did see in the Q&A document that was sent prior to the call that in the CARES 2 site, you're not allowed to store occupational data, which I'm not really understanding at this point. But, is there an update about when we're going to be able to capture data specific to agricultural workers? I would also say from a practical standpoint, having now done multiple events with farm workers where we're both doing pre-registration and allowing for walk-ins, that there are multiple steps where farm workers are getting asked the same questions on different sites. So we'll pre-register them. They're asked the same question by the medical provider, and it's like 2 or 3 times they're being asked the same number of questions. And so we got a lot of feedback from the workers, like, why are you guys asking me this over and over and over again? We've already answered these questions. I'm so just wondering if there's a way to also streamline the process, especially as we're looking at an equity lens for those who might not be able to call in to get a registration or have access, digital access. Doing the walkthrough process was a little bit painful, and so, to say the least, because of those multiple steps. So just wondering what it is that can be done on that end as well.
Well, thank you for that. I will take that back. I think it's a combination of the My Turn team and our TPA process. So I will take that back. I took good notes. So thank you for that feedback.
Okay, we have time, I think, for one more comment before we move on to our next section. So Amanda, do you want to go next?
Yes, thank you. Amanda McAllister Wallner, she, her, hers, with the California LGBTQ Health and Human Services Network. Two thoughts on the second part of your question. What do you do with that feedback? You know, how do we create that feedback loop? What do we do once we have that data? The first, and I put this in the chat, so I won't go into, extreme detail, but I think, one part of that feedback loop has to be data quality improvement and completeness. For instance, we know that since the summer, since last summer, we haven't had a great completeness on sexual orientation and gender identity data. We're only getting, I think, under 10% of counties, providers, et cetera, reporting sexual orientation data. And so what's the plan? What are the different actors within the system doing to address the various different points where that data is being lost or is not being reported up the chain? I think that, we know that there are problems. And so I think with getting that data, and we know that there are problems that are preventing us from being able to do that analysis by sexual orientation and gender identity. So, what are the steps to address that so that we can start using that in our analysis of equity? And then the second thing, within this feedback loop, I think is that I just want to highlight, I think is transparency and communication. So, we're doing, we're doing this work, the folks on this call and others are, identifying problems in the system, access problems, or, where we're not reaching communities. You all have identified a solution, or someone's identified a solution. How do we make sure that we're communicating to the public this problem you are having is, has been addressed, and so that folks, know how to navigate that system and have the most up-to-date and current information. Because I know that you all are, and that everyone is working really hard to handle all of these issues, to make this process as smooth as possible. And as equitable as possible. And we need to make sure that our communities are getting that information and that people know, what's happening so that they're not going to run into those problems anymore, and that they can try again now, or they can, do it this other way that's been implemented.
Great feedback. Thank you.
Okay, I just want to ask Kim, who represents the California Health Administrators and who's on our committee, just to say a few words about her response to the question was asked about where are the counties and are they on board or not. So Kim, do you want to just introduce yourself and just take a minute to respond to that, and then we're going to move on to our next agenda item. So for those of you that had your hands raised, if you don't mind putting your comment or your question in the chat, it would be great.
Bobby. So I'm Kim Sarotari, Director of Public Health for Riverside County. And I also know Dr. Serjenko is on the call too from, he has 2 counties that he represents. But I will say, I think that there's a tremendous amount of credit that goes to the state and to Blue Shield for working through this with the counties. We were very far apart when we started this, this process. And I think that all of the parties really negotiated in good faith and came together and addressed what the issues are for the county. And so now we went from a contract with Blue Shield to now we have an MOU with GovOps at the state level. And it was as recent as last night that clarifying pieces came out that gave counties some additional flexibility written down in terms of being able to redistribute within clinics that we are contracting with or controlling staffing, so public health type clinics. And so we were really happy with the way that the state and Blue Shield worked with us on this. And I'm happy to say that we actually signed our agreement this morning and got it fully executed back from the state shortly after that. So I feel like we've come a long way. And now that we're kind of over that hurdle, I think most counties are fairly happy with the way that the MOU came out. I certainly don't speak for everybody, but at least in the conversations I've been involved with. And I think everybody now is just looking forward to, okay, let's get our focus back on getting vaccine in arms. So.
Thanks, Kim, for jumping in. And Nadine, I'll turn it back to you for our next section on community engagement and outreach.
Thank you, Bobby. So it's my pleasure now to introduce Marcela Ruiz from CDSS, from the California Department of Social Services, and Dr. Martha Dominguez from CDPH. Whoop, are you there?
Hi, all. This is Marcela Ruiz with the Department of Social Services. I hope you can see and hear me. Next slide, please.
Oh, Stella, we can't see you, but we can certainly hear you well.
Okay, then I will turn off my video, which doesn't seem to be working. I actually believe that Martha is up first, so let me pass it over to her.
No worries. Good afternoon, everybody. Thank you for allowing us to be in your space. For those that are celebrating St. Patrick's, happy St. Patrick's. Super excited to give you some update on our progress and share some of our goods that we have been producing. Just as a recap, I know I have talked about in the last couple of meetings on the research framework. Just wanted to give you sort of a bird's eye on what that research framework works in terms to monitor attitudes and beliefs across the duration of this campaign, but specifically within our disproportionate affected communities. We have 2 approaches, a qualitative and quantitative. I've already shared literature reviews, stakeholder in-depth information interviews, which a lot of you supported us in that process. We also did dyads and triads generational online sessions. We also did online discussion boards, and we did also multi-ethnic focus groups. And then we will continue our research will continue with some quantitative monthly tracking survey, collecting information across the 12 months along the duration of the campaign. Next slide. So what is a quantitative tracking survey? So the tracking survey really is encompassed of a pre-campaign benchmark wave, which we're calling wave 0, and then they're followed by a monthly waves. The type of survey questions that we're going to be tracking is really direct questions on the likelihood of getting vaccinated. We know that this is constantly changing as people are obtaining information, but really to monitor the hesitancy of how that's fluctuating within communities. We will also have direct questions about COVID-19 and vaccines to gauge the truthfulness, to answer direct questions on the likelihood to get vaccinated. Just some logistics about the survey. The survey is conducted online and it's via telephone to ensure coverage of the hard to reach residents. Our minimum sample size, which we will supersede, is 1,200 participants across California, primarily in 3 regions, or as we're dicing, California, Northern, Central, and Southern California. What we hope to learn is really to measure track the shifts of vaccine hesitancy throughout the year, which will be really important. We will also measure and be provided of how Californian population as a whole, and also some subpopulations selected based on the findings in regards to vaccine hesitancy. More specifically, we're interested in tracking the African American community, Asian Pacific Islander, English dominant and bilingual Latino households, and Spanish dominant Latino households. So that's part of the quantitative tracking study that we will be doing. Next slide. Keeping all the research that we've been talking in the last couple of weeks or in the last meetings that we have, just wanted to underscore that research has really indicated to us that there are key factors that can empower us to get the communities to get vaccinated. Really is trust, making sure that we connect people with the right messengers. We know promotoras or people within their community are becoming the trusted and right messenger that can deliver that information for them and have that conversation. We want to be super transparent about the various different angles of the vaccine process or just vaccine information that people have. So we want to disseminate that information. But we also want to uplift any humanized lived experiences. We know that a lot of our communities are what we're calling in the wait and see category. They're waiting for others to get vaccinated until they can get vaccinated. And the more that we use an approach of testimonials and show people that people like them are getting vaccinated, or people like them were part of the clinical trials or part of the process, people that's resonating, and it's allowing them to really make an informed decision for vaccine acceptance. Next slide. So we wanted to unveil our campaign strategy. We have gone through creative testing. We've talked to various communities, and we feel that this campaign named Let's Get to Immunity, and there's an emphasis on unity, will meet people where they're at, but most importantly, it really will provide that information. Consumers will feel understood, they'll feel informed, but most importantly, motivated to get vaccines. The findings during our creative testing really validated and quantifying that this work really is really important, and the messaging and the approach of it can reach the audience that we're hoping to reach, and also to see people like them across the campaign represented, and the imagery and the messaging along the way. So wanted to unveil this for you. Let's Get to Immunity is our brand to deliver our message in the next couple of months. Next slide. Within our Let's Get to Immunity brand campaign, we are developing multicultural, Latino, Pacific Islander, and Asian creative that really has imagery, as I indicated before, people that reflect like them. We want to make sure that people can see themselves in the imagery and that the information and the messaging is right for them. We are working with very robust and sophisticated ethnic media partners that are helping us to ensure that the messaging and the creative assets really meet people where they're at. These are sample creatives that will be going digital, at a home, which is the billboards, but you'll also see them in grocery stores. You'll also start to see them in print ads. Last week, we unveiled our radio. This week, we also launched our paid and our digital search. Next week, we will be launching our TV and print and at a home. So we will have a full-blown campaign in the next couple of days. Next slide. We wanted to share with you one of our pieces. It's called Anthem Radio. And the reason why it's called Anthem is really we want to make sure that people really understand that we're hearing them. We know a lot of people have questions. We know a lot of people have concerns. And then we want to make sure that they understand that that's okay, that there's hope, and the vaccine is hope on its way. So I wanted to showcase today our English radio. So Bobby, if you don't mind clicking on the little speaker for the team, I would love to share the radio spot
Okay,
with them.
that you don't want to be first to get the COVID-19 vaccine. You aren't. It's okay to have questions. Everyone deserves answers. It's okay to be excited or worried or both. All your feelings are valid. It's okay to hate needles but love Band-Aids. It's fine to do it because your kid misses her soccer team like nothing else. It's all right for it to take whatever it takes for you to be ready. Let's get you there. Let's get to immunity. Learn more at vaccinateall58.com.
So that is our radio ad, and we also have it in Spanish. We also have it in Asian and Pacific Islander. It is a multicultural, in-cultural campaign that is reaching Californians across the state. Next slide. We also teamed up with our big champion, Dr. Brooke Harris, specifically around various types of messages, but this one in particularly, we wanted to make sure that people understood the importance of the Johnson & Johnson vaccine. We learned that the community had a lot of questions. People wanted to get clarity. And we released this video for social and digital to both in English and Spanish to really allow the community to understand and see someone that is so credible like Dr. Brooke Harris to deliver that information and to really get that peace of mind of underscoring and that reassurance that the vaccine is effective. So with that said, I would like to showcase with you the video. So Bobby, do you want to hit play?
Hello, I'm Dr. Nadine Burke-Harris, Surgeon General for the state of California. We've reached an important milestone for Californians as a third COVID-19 vaccine has been supported for use. The FDA, along with an independent group of nationally acclaimed scientists with expertise in immunization and public health, have completed rigorous reviews and concluded the Johnson & Johnson COVID-19 vaccine is both safe and effective.
That was the English spot, and we also have a Spanish spot. Next slide.
La vacuna Johnson & Johnson ya está aprobada para su uso aquí en los Estados Unidos.
Bobby, were you able to play the Spanish, or do we need to move along?
I think we had a little technical glitch there.
La vacuna Johnson & Johnson ya está aprobada para su uso aquí en los Estados Unidos. La diferencia entre las vacunas Pfizer y Moderna con la de Johnson & Johnson es que solo se necesita una dosis. Las tres vacunas pasaron por rigurosos ensayos clínicos y demostraron ser seguros y eficaces para todos los adultos. Los efectos de COVID-19 son mucho más extremos que cualquier riesgo potencial asociado con las vacunas.
Yes, this type of messaging really, really hit home for a lot of our Latino communities, and also the previous English message. People really had a lot of questions and concerns, but this really underscored for them that sort of reassurance. So we're very appreciative, and I know we will be tapping to a lot of your expertise, but this type of messaging and that reassurance is really critical. And with social media and digital, which we often see as a first line of defense to deliver messaging, it's super critical. So thank you, Dr. Burke-Harris, for lending your voice and allowing us to do this piece. Next slide. The other factor that I underscored earlier in the presentation is people want to see people like them. They want to see people like them really understand and feel that same emotion. We know this has been very emotional for the various communities, but testimonials is a really great approach for us to get that message out and amplify that movement within various communities to ensure that they can feel confident and secure by getting the vaccine. So I want to show you a clip. This is in Spanish, but we also have other farm worker testimonials in Hmong and in other languages. So for this one, we'll be in Spanish. So Bobby, do you want to hit play?
Ahorita solo siento un poquito de presión en la mano, pero todo bien. Quiero visitar a mis familiares, quiero darles el abrazo, pues que ya tiene un año que no se les da el abrazo, ¿no?
Just to underscore, her message is really the sense of relief of getting vaccinated, to see and hug and see their families. And this is a sentiment that we're seeing across various communities. Within the farm worker community, it's something that really is resonating. So we will be showcasing this more as a campaign develops. Next slide. Also wanted to share with you guys that our PR team has been hard at work around the arrival of the Johnson & Johnson vaccine, especially doing some surgical PR efforts, which really included proactive pitching of interviews with their subject matter experts, both mainstream and multicultural media. It really resulted in a great cross-section of coverage, as you can see here. These tactics were designed to build confidence on the Johnson & Johnson shot, positioning not only as a safe and effective along with the Pfizer Moderna, but also highlighting that it's easier to transport and store because of the freezer requirements aren't so stringent. And because, as you heard, it's just one and done. Next slide. We also did a Johnson & Johnson PR tour, and you'll see some familiar faces here, but really further to we produced 2 media events, one in Oakland and one in LA, where media were able to come and feel and cover the vaccination of our state doctors. Dr. Pan, Dr. Burqueras, Dr. Tomas. We also had Dr. Diana Ramos. This really allowed us to really connect with the media and help us elongate those messages. And as I mentioned earlier, one of the factors is for people to see people like them that really are taking that initiative and on the vaccine acceptance. So we're very thankful for their participation. Next slide. Just wanted to also share and highlight that the Governor's Newsom's most recent on the record column highlight not only the safety of the vaccine, but also California's commitment in distributing the vaccine in an equitable manner. Equity, of course, is a North Star for all the work that we're doing. And thanks to the collaboration of our campaign ethnic media partners, the column ran in more than 40 outlets, including many in language. Next slide. On our ethnic media briefings, our Earned Media team also developed and produced another series of ethnic media briefings for multicultural journalists to continue the education around COVID vaccines. We held 4 separate briefings, one for African American media, another for Asian American, Pacific Islander media, another for Latino media, and finally a briefing for Native American media. In total, we have hosted 117 news outlets and earned a lot of informative and positive coverage for multicultural and ethnic audiences. Next slide. And lastly, I want to invite you, if you have not signed up for our newsletter, please sign up to our newsletter by emailing the va58@cdph.ca.gov. The newsletter includes a lot of goodies such as key messages. It includes highlighting some of our assets that we will be sharing. We also will be developing various types of toolkits so you can help us amplify that information in your social media channels, but also to ensure that collectively we have one unified messaging for our communities. So please send us an email. We would love to have you in our distribution. Next slide. So I think I'm going to pass it to Marcela, but before I do, Bobby, I'm not sure if you're able to tee up our new TV ad. If time permits, I would love to share this with the committee. We're very proud of our TV ad that launches on Monday. So here is our biggest pride and joy.
It's okay that you don't want to be first. You aren't.
Second COVID vaccine.
It's okay to have questions. Everyone deserves answers.
I'm wary that there isn't enough information.
It's okay to be excited or worried or both. It's all right for it to take whatever it takes for you to be ready.
Hi, Mom. Ready for your shot?
Yes, I've been waiting for this day.
You just got what? Vaccinated. We just got vaccinated.
Let's get you there. Let's get to immunity.
Yes, thank you. Thank you for your time. We hope that you love our products, and I'm happy to take any feedback. You'll also have my email. I'm constantly making an assessment to ensure that we do work and in a good way, but also make some improvements along the way. With that said, I will punt it to my colleague, Marcela.
Thank you, Martha. And my video is still not working, so I apologize for that. And I have to say that I think it's a little bit unfair that I have to go after Martha. I always get a little bit choked up with the videos and the messages, and I think we can all relate to the hope and the joy that's expressed from the idea, right, that we will be able to come together as community in unity soon enough. So I get the task of giving you an update on the work that many of you are doing. So I get the opportunity to reflect back to you the great work that you are doing to get the word out about COVID-19. A few updates on the community-based outreach efforts that are funded through the state and also in partnership with philanthropy. Last week, we announced 49 new partners through the California Community Foundation who are focused in Orange County, Los Angeles, and Ventura. So this brings the total state-funded partners to 157. And as you remember, these are the partners who are funded through the Department of Social Services and also our sister agency, Labor Workforce Development. We are onboarding the Southern California-based partners through CCF this week. So we had our first onboarding session this week, earlier today rather. They are rounding out that onboarding and will begin doing their outreach in the next week. Our partners in philanthropy with the fund that is administered through the Public Health Institute continue to make awards to community-based organizations as well. As of mid-February, they have made awards to 180 plus partners. And collectively, between our efforts at the state and our efforts and the efforts through the Public Health Institute, we have awarded $52.7 million through 337 CBOs. So that is quite a significant effort, and really proud of that. Really proud to be able to partner with many of you who are on this on this committee. Next slide, please. So here is really where I do get to tell you what you've been up to. In the first 2 to 3 weeks of the partnership with the Center at Sierra Health Foundation, organizations on this call and other organizations who are receiving funding reached over 80,000 individuals through phone banking, door-to-door outreach, canvassing, booths and tabling. And what you will see on your right are the activities, the number of activities. What you see on the left are the number of people reached in that short time span. The organizations are reporting on a weekly basis. We're happy to share that information with you at the CVAC so that you can see how active our partners are in getting the word out about COVID-19. Next slide, please. So just as a kind of a reminder and to situate this project, I think it's really important to remember that this project was initiated before the vaccine was really a reality, right? And so this partnership with our community-based partners began as an effort to do outreach around COVID-19 mitigation strategies. And on the labor workforce development agency side, it was really focused on mitigation strategies in the workplace. But we all know that it is important to respond to the moment, respond to the opportunity, and many of you are doing that. Many of you are hosting vaccine sites. You're supporting enrollment through My Turn or other processes, sometimes in coordination with local county health departments, sometimes in coordination with state-sponsored sites. You're supporting wraparound services, including transportation, on-site registration, interpretation, because we understand that for there to be a successful vaccination, the enrollment in an appointment is the first step, but actually getting somebody to the site, making sure that they get the first dose and the second dose, making sure that they're able to communicate with the providers is all part of this process. And you're also referring individuals to vaccine sites. So I'm just lifting up some of the practices that are emerging. And we are in a phase right now where with our project where we are piloting some of these efforts across the state to learn how to connect the CBOs more tightly with the vaccine supply as vaccine ramps up. So we really do think it's going to be a terrific opportunity as the vaccine supply increases, as the third party, as the TPA connects with the counties, as the counties sign on to the TPA. We are also working very closely in partnership with the TPA to understand how to make that connection more tighter. And so I do want to also thank Peter and Kimberly for the partnership and really thinking through how we connect the community-based organizations with the network. Next slide. And so I am looking here to Bobby for cues. I know we're almost at time, and we wanted to put a few questions on the table, but Bobby, I don't know if we want to go to the overall Q&A and table this conversation, or if we want to share the questions, have folks kind of write in with responses, or how you would like to handle the amount of time we have left.
Thanks, Marcella. I think it would be great. The questions are up. You can see them. If you have comments you'd like to make in the chat, we'll make sure that Marcella and Martha get your comments. And if you want to talk further with either of them, if you can just put that in the chat as well. And we probably have time for 1 or 2 verbal comments if anyone wants to raise their hand and either ask Marcella and Martha a question or comment on the questions that are on the screen. So we'll leave these questions on the screen if that's okay. And we'll take, we'll see how much time we have left. We'll take at least 1 comment if maybe we have a second one we'll have time for.
Thanks for that, Bobby. And so I'll just preface the questions by saying, as we understand how to connect the CBO network and other CBO partners that may not be part of the state-funded network with the vaccine sites, we're really interested in hearing from you what effective strategies you have identified connecting individuals with the vaccine and what supports you think are most necessary to make sure that someone who receives an appointment is actually able to show up for the appointment. We are gathering these best practices as we go along and work with you, and appreciate your feedback and your input, because I think this will really inform navigation-like strategies that the state is developing.
Great, thank you, Marcella. Let's start with Genevieve. Genevieve, introduce yourself, and if we have time, we'll go to Ronnie. Let's just see how we go. Go ahead, Genevieve.
Hi, everyone. Good afternoon. Genevieve Flores Haro, Associate Director with Mixteco Indígena Community Organizing Project, or MICOP for short. She, her, they, them, ella, ella. I wanted to touch on the second question, supports to make sure someone shows up for their appointment. What we're seeing, especially now that it's open to farm workers, at least with the state portal as it is right now, it's still requiring an email address, and the confirmations are getting sent via email. So that as we're registering farm workers, we've had to make an email address. I don't know if that's allowed, but we made an email address so that our promotoras can make sure to remind them directly via telephone. So maybe taking that out of whatever platform gets developed next. And secondly, I went and I visited one of our vaccine sites out here, and just wanting to really impress the importance of language access. The vaccine site I went to, I asked, if there was a monolingual Spanish speaker, how would they be processed? I was told someone at registration speaks Spanish, but all the nurses spoke English, all the instructions were in English, and just wanted to lift that up. I know equity, language access, and these spaces are really important. We just got to make sure that implementation occurs on the ground. And so if it's not there for Spanish, it's not going to be there for our indigenous languages as well, like Mixteco, Zapoteco, and Triqui. So again, really good stuff coming from these meetings, and now's the time to make sure that they get implemented. So thank you.
Thank you, Genevieve, for underscoring that's so important. Ronnie, we'll take a quick comment from you, and then I think anyone else that wants to comment, if you could please put it in the chat because we've run out of time.
Thanks. Ronnie Kelly, County Behavioral Health Directors Association. So for the first, we actually have just set up for County Behavioral Health our own clinics. We've gone through CalVax, did the whole system because we knew that our patients who have disabilities were not going to wait. They were not going to be able to access other systems in order to input all the information. We know that health literacy is very low nationally, certainly within our populations. And we really listened to what they said to us. We actually held listening sessions with our communities and said to them, what do you want to know and how do you want to receive information? And we didn't say, well, no, that's not true. We didn't interrupt them. We just listened to them and then we did it. So that's been very effective for us. And even to make sure that they showed up for the appointments, we have their caregivers who are part of it. We have their favorite clinician or their psychiatrist who's seeing them anyway. And that's how we're doing it, just so it's a one-stop and isn't requiring multiple screens or multiple sort of processes.
Thank you, Ronnie, for bringing that up, a great example. And I think we'll turn the meeting back to Dr. Burke-Harris and Dr. Pond to close us out and get ready for our next session.
Thank you so much, Bobby. And thank you again to all of you for another really excellent meeting, really thoughtful feedback. I want to reflect on some of the things that we heard. We made a commitment to bring back to you data by race and ethnicity, by age, and also to share with you at the next meeting information on the role of Kaiser and the TPA, their workflows, their dissemination in terms of accessibility and prioritization. So we'll look to finding those answers. I want to lift up the voice of my sister, Maria Limas, who is, continues to pound on the table about promotoras. And I want to emphasize that CDPH has given that guidance that promotoras are eligible as healthcare workers and make sure that everyone is aware of that. We heard a great recommendation about developing messaging about waiting for the preferred vaccine. And in fact, what we heard so eloquently from our public health officer, Dr. Aragon, at our event last week is that the best vaccine is the first one you have access to, right? So that's, if folks are wondering which is the best one to get, it's the first one you can get. We also heard a request to learn more about the state's plans for accessibility for the homebound. And so we can work to bring more information back on that at our next meeting. I will say my own mom is homebound and received her vaccination last week. I was amazed to see how well that happened. For folks without access to computers, there was that question raised. The information was put in the chat, but I just want to reiterate that the number is 1-833-404-5678. 422-4255 for folks who want to sign up for a vaccine who don't have access to a computer. Thank you for all of your suggestions on what data to track and how we can operationalize equity for our TPA partners at Blue Shield. We also heard requests to send out information about eligibility for families engaging in the CCS program. I want to thank Christina for lifting up the resource and the roadmap for individuals with disabilities to navigate the system. And we will make sure to include that in the materials that we are sharing. And finally, reflect back that we heard the recommendation about having information about getting vaccinated in American Sign Language. I want to thank you all for sharing these messages with your constituencies and lifting up the excellent work that's happening. I really want to give a huge shout out to our teams at DSS and the GEO and CDPH in terms of this very, very powerful and nuanced messaging. I think I saw many messages in the chat reflecting on the excellent work that's happened there. And finally, I want to say that in light of the president's announcement about broadening accessibility to the vaccine by May 1st, as we look forward, we will have our next meeting on April 14th as we transition now to monthly meetings. And then we will likely wind down the work of this committee by summertime, likely in June. I want to thank everyone again for a really wonderful and robust meeting, and offer to the floor to Dr. Pond to close us out with a few final words.
Great, thank you so much, Nadine. Just want to, again, really appreciate the thoughtful input of all of you. I think we wouldn't be where we are, and we won't continue to get better unless we get this amazing feedback. And I also just am equally so touched by the immunity campaign. It's so right on. I really look forward to hearing more feedback on that, and hope all of us can continue to get those words out. And again, just reflect, we're in such a different place after a year ago, having just had been told we all would need to stay at home, and now we are vaccinating away, and we really are well on our way to our community immunity. So thank you for your participation in that and for your partnership moving forward. Thanks so much, everyone.
Thank you, everyone, and the meeting is adjourned.
Thank you.
Thank you.
All soon.
Thank you.
Thanks. Good evening.